Okay, I think this is a good time for us to begin. Good evening, everyone. I am Michael Joseph, Associate Professor in the Department of Epidemiology, and also Vice Dean of Education at Columbia University Mailman School of Public Health. I would like to begin by thanking everyone. I thank all of our attendees for joining us for this evening's panel session, which will cover this topic: how to be an anti-racist public health practitioner. And I must say, what a fitting and timely topic this is. A few weeks ago, our moderator, Dr. Bob Fullilove, reminded me that we could not have chosen a more appropriate date for this evening's panel session, as today, April 4th, 2022, marks the 54th anniversary of the assassination of the Reverend Dr. Martin Luther King Jr. As you know, Dr. King was a huge proponent of anti-racism and lived his life fighting tirelessly to end racial discrimination and segregation here in the United States. And as we look back into the rearview mirror and reflect upon these past 2 years of the pandemic, we know COVID-19 has exacerbated health disparities, already burdening people of color, and the pandemic has coincided with the powerful movement in anti-racist activism across the world. With that being said, tonight's panel is part of our school's Face Forward Anti-Racism Seminar Series, a seminar series that is one step within a larger roadmap guiding the Mailman School of Public Health toward becoming an anti-racist institution. So whether you're a part of the Mailman School or a friend of the Mailman School, we welcome you tonight and hope you will enjoy hearing from our distinguished group of panelists assembled for this virtual discussion. Joining us today, I will begin with Dr. Marilyn Frazier, a longtime friend and colleague of mine who is the Chief Executive Officer of the Arthur Ashe Institute for Urban Health, located in Brooklyn at SUNY Downstate Health Sciences University. The Arthur Ashe Institute is known for meeting people where they are in its efforts to champion health equity and community wellness. Welcome, Dr. Frazier. We also have Dr. Rahsaan Harris, Chief Executive Officer of the Citizens Committee for New York City, whose mission is to help New Yorkers, especially those in low-income areas, come together and improve the quality of life in their neighborhoods. Welcome, Dr. Harris. We also have Dr. Simona Kwan, longtime friend of mine also, social behavioral epidemiologist extraordinaire and proud Mailman DRPH alum from the Department of Sociomedical Sciences. Dr. Kwan is an associate professor and vice chair for diversity, equity, and inclusion in the Department of Population Health at NYU Grossman School of Medicine. And last but certainly not least, we have another proud Mailman alum who received her MPH degree from the Department of Health Policy and Management, Dr. Aletha Maybank. She is the Chief Health Equity Officer and Senior Vice President for the American Medical Association, where she focuses on embedding health equity across all the work of the American Medical Association and leading its Center for Health Equity. I'd be remiss if I didn't acknowledge our wonderful visual note taker, Abby. As our panel discussion is taking place this evening, Abby will visually capture the conversation through her drawings. Trust me, audience, you will be thrilled with her drawings. Thank you, Abby, for joining us once again. Audience, here to facilitate this evening's conversation, we have the one and only Dr. Robert Fullilove. At the Mailman School, our students affectionately refer to him as Dr. Bob. He is a professor of sociomedical sciences, associate dean of community and minority affairs at Columbia Mailman, and a living legend when it comes to examining health disparities impacting communities of color. Dr. Bob, this virtual floor is now yours. Thank you.
Thank you so much. Dr. Joseph, it's always a pleasure. So glad to welcome all of you here this evening. And if I might, Dr. Joseph, I want to pay particular homage to the fact that you recalled the significance of April 4th. I recall very, very clearly that on that night 54 years ago, I was waiting tables with other students at Union Theological Seminary at Riverside Church when someone came out and told us the event tonight has been canceled. We've just learned that Dr. King has been assassinated. I went home, and for those who were alive in that period, you'll recall that for about 36 hours, we watched many major urban centers burn down. That's a way of sort of recalling the importance of the topic for this evening. And I want to be very clear that it's perfectly correct to invoke Dr. King's name at this moment, because in the struggle to be anti-racist, we are suddenly finding that we are confronting, as Dr. Joseph pointed out, not only a public health crisis, we're also at a period in time where we're not quite clear whether or not George Floyd's murder is an occasion for us to be aggressively anti-racist, or whether or not this is a period, I'm thinking of President Biden's State of the Union address, when instead of defunding the police, we're in many cities in this nation calling for more. What does it mean to be anti-racist at this point in American history, a particularly important point as we face the midterm elections that are coming up in November of this year? So let me begin by asking each of you on the panel, if you would. We don't want to assume that everybody knows what it means to be anti-racist. I would be honored if you would give us, each of you, some sense of what it means for you. Why is that term so important? And if it's possible, say a little bit about how it impacts your work. Dr. Maybank, since you're the one who's right below me on the screen, may I ask that you begin? And so good to see you.
Oh, no, it's awesome to see you. Thanks, Dr. Bob, and thanks, Dr. Joseph. You have another job there and another calling, and however you introduced, that was amazing. But thank you for the panel, and just awesome to be in the presence of mailmen and mailman energy. So for me, in thinking about anti-racism work, and there's a quote from, Ibram Kendi's book on how to be an anti-racist, is to be an anti-racist is a radical choice in the face of history, requiring a radical orientation of our consciousness. And, in the work that I've been doing, especially around narrative work and shifting narratives and people's understanding about narratives, I think this work of anti-racism is about a shifting critical consciousness, or even developing a critical consciousness. Coming from the space of public health and now more so into healthcare, just realizing like the tremendous gap in people just understanding kind of these root causes and these systems of power and oppression that are present and so pervasive in our society for since the beginning of time, right? Since we've been here. But so many people are either ignorant to it, not wanting to see it, not knowing it, not understanding it. So for me, in this space of doing it at an institutional level, it's like, how are we building that critical consciousness for people to see it, and see how it upholds our kind of false notions of hierarchy based on human value, with white being on top, or white supremacy more specifically. And what are the actions that people have to put in place in order to demonstrate when they say they are doing anti-racism work? And that, I think, leads to what is the accountability that people need to have, as well as institutions. So at the AMA, founded in 1847, has its history of being racist. I say all the time, it's kind of the demonstration that people kind of go to for, it's like the poster child of racial injustice, really, in medicine to some level. And really, its foundations have been very critical to keeping in place and building and using science to kind of justify the inferiority of people that still exist today, these thoughts and these notions, these narratives, and how it shows up in our science and how it shows up in our work. Very much we have to look at, the role of the American Medical Association. And in addition, and Dr. Bob and I have had conversations about this, they explicitly excluded Black physicians for over 100 years. And so there are many ways in their actions and in their policies that has just shown up. And so a few years ago, there was explicit movement of the House of Delegates by the AMA to have a focus in an organizational unit that was going to focus on equity, with a person, myself, to lead that work. Now, I would say initially it was equity, and there's a distinction, and that's another point to kind of talk about later, hopefully. Not necessarily explicitly anti-racism work, but will say that COVID-19 the exposure of disparities and the public murder of George Floyd, to your point of what you mentioned, shifted AMA and what they were going to talk about. I think a lot of people, and explicitly now talking about racism and racism as a public health threat and crisis. And that was to the shock of many, not only just those who did not want to talk about racism, but even us who talked about racism. They weren't expecting AMA to put out anti-racism policies. And so a lot of the work that we've been doing over the last year, understanding these doors of opportunities don't open all the time. How do we capitalize on that? How do we put out a strategic plan that is forwardly saying this is to advance racial justice, and using that and leveraging that and putting forward ideas around that of how medicine, in addition to public health, can organize around anti-racism.
That is quite a lot and extremely impressive. We will return to some of the points you made. I'm especially interested in the notion of equity and how that fits into an anti-racist agenda. But Dr. Frazier, if I can switch to you, I am someone who was very active and still am to some degree in work with HIV. And of course, one has to recall how much that impacted the person whose foundation you sort of represent here. And I'm thinking that because you're in Brooklyn, one of the places that has always had a very, very high incidence as well as prevalence for HIV, I keep thinking that anti-racism for somebody who's doing community work in Brooklyn must have a particularly significant aura for you and your work. I wonder if you would like to comment on that.
Oh yeah, definitely, Dr. Bob. In terms of the work that we do, and just even thinking about Arthur Ashe, some may think that he was before his time, right? In thinking he was an activist. In addition to being a tennis champion, he was an activist. He was a humanitarian, and he was very intentional with creating the institute. He wanted it to be in a place, as you mentioned, in Brooklyn, where health inequities are rampant, right? When we talk about health disparities, we know that we can pick any one of the topics on health and we can see the disparities across our communities. And when Arthur Ashe founded the Institute, some of the things that were central to that were for us to make sure that we were going out into the communities, promoting health equity, making sure that there was equitable health care, because Arthur knew that although he was privileged in some point, he still faced disparities in health, although he had, and he would be someone that may show up that had the means and the opportunities. Still, there were disparities, and so he was intentional in finding the institute and creating the institute so that we can address some of those things. So we go out into communities of color, go out into beauty salons and barbershops, and talk to people about health, and make sure that people are linked to services and linked to those care that they need. And also something else that was important in the Institute was to create a health science academy, an academy for people of color so that we can increase people of color in the health professions. Because when we talk about equity and we talk about racist practice and so forth, we have to look at the school systems, and we have to look at make sure that equity is there. And when we found the Health Science Academy, that's with students are interested in the health professions and making sure that our students are getting the advantages and the things that they need so that they can compete, right? Because we know that all things are not created equal, and our students at various times, we have bright students that would go through high school and when they get into college in the sciences, they're weeded out in their first year. And we wanted to make sure that our students understood that disparities exist and how do they attack racism and racist practices. And so when I think about racism, I think about all the policies and all the systems and all the structures that we need to dismantle, whether it's access to care, when we're going into communities of color and we're thinking about insurance, for instance, that people may not have insurance, and then they may have insurance, but the specialists may not take their insurance. So we need to do all of those things, make sure that we are dismantling those systems and some of the systemic things that Dr. Maybank mentioned, that we need to dismantle that, and looking at all the social determinants of health, looking at housing and transportation, access to food, access to care. These are systems and structures that we need to recognize that they do not work, recognize that there's racism there, and then attack those things and dismantle them, because if we keep on doing the same things, and we would not going to change the systems in which we live.
Well said. Very well said indeed. Dr. Kwan, if I can pick on you for a second, good to see you again after a number of years. I'm very curious about your work there because part of your title involves you as an administrator whose job it is to focus on issues of equity. So in a conversation about anti-racism, might you say something about what that means for you and the work that you're currently doing?
Thank you, Dr. Bob. It's great to see you. I characterize myself as a community-based participatory researcher focused on health equity research and working in partnership with communities. We understand racism is a root cause of health inequities, just like Dr. Maybank shared. And as public health practitioners and as researchers, we have to apply an anti-racism lens to really move the needle to get to population health equity. And so we have to apply a racial justice lens to the work that we're doing in our everyday research, the way we look at data, the way data is collected, and to understand that individual level interventions are not going to make those changes. We have to also put our lens and our approaches on the multiple systems levels, policy advocacy. We have to change infrastructures, and we have to really look at how do we message this across not only the public health communities, but politicians, across the for-profit and the nonprofit sectors. And so, building on the work of coalitions and capacity building and centering our socially marginalized communities rather than the status quo. So much of public health research and the gold standard of research is focused on the general population. We know that if we were developing strategies and programs for socially marginalized communities that are underrepresented in research, there's less work that we would have to do in terms of adapting programs. It's just I think we just need a paradigm shift in the way we're approaching programs and strategies.
Paradigm shift. Okay, that's a theme I think that is worth our returning to. Dr. Harris, certainly the last on my list of folk to call on for this introductory set of comments, but by no means least. Am I correct in congratulating you? Are you just like slightly less than a month in a new post?
Well, actually, it is the second anniversary of the first month of when I started this job. Talking about coming in the midst of crisis, my first day on the job was March 16th, 2020, when the pandemic became real for New York City. A lot of the institutions were closed down, and it was an opportunity for us to try to lead and provide services in the midst of all that was going on in New York City.
That, I think, provides a perfect window to ask you the question. Having been at the core of this crisis, and I think because all of us are based in New York City in one way or another, I'm really curious to know, thinking about your experiences way back when, from March 16th to this point in history now, when you think about looking at work through an anti-racist lens, what does that mean for you?
Well, Dr. Bob, thank you so much. And all of these panelists, it is humbling to be included in this conversation about health. Citizens Committee creates opportunities for average everyday New Yorkers to improve the conditions in their neighborhoods. And we believe that healthy neighborhoods lead to healthier outcomes for folks. And the way we've done that work is providing micro grants to people who come together to solve a problem that they identify in their community. We were founded in 1975 in the midst of the financial crisis that was at the time. And interestingly enough, I came in a moment where there was a great crisis in New York City. The work at that time was really a lot about folks coming together and just identifying problems, whether it's cleaning up a block or providing after school services for young people or helping older adults to do things that gave them more life and vitality. Well, given what happened with COVID, when we first saw the crisis, we recognized that if you looked at data but didn't disaggregate it based off of who was being affected negatively from health outcomes, you didn't realize that Black and brown communities were dying at 2 and 3 times the rates of some of their white colleagues. And so that took our history of being there for community and getting out and providing resources for folks, which was at the heart of what we're doing, but we needed to be intentional and understanding how your race or ethnicity can be a predictor of what kind of outcome you were going to have. We needed to be intentional about what kind of interventions we were going to provide and what kind of supports if we were going to provide the highest amount of impact and get to New York City's most vulnerable communities. So looking at the data differently, being out there in community and explicitly talking about who we were supporting. Historically, we've supported women and people of color at higher rates than others, because those are the folks that are applying for grants and asking for services and providing solutions in their communities. Well, calling that out and speaking to it as an asset was really important for what we were going through in that moment, because it showed where leadership for New York City was going to come from and showed what were the mechanisms for providing better conditions for people in community. And people who are running block associations and beautification projects and community gardens in 2019 in March, in 2021, they were providing access to PPE and masks and hand sanitizers. They were providing folks access to where to get vaccines and telling them and providing information that's really critical for ambassadors and community to be trusted sources of information. And there was just a pivot in the way we did our work, and being able to see folks as different types of leaders that can change conditions in communities that hopefully will lead to better outcomes became more central to what we were doing.
If I can continue, many of the folk who are watching this webinar are students who are going to go out into the world. Many of them will go into the communities in New York where you have been so active. I think these webinars are opportunities for us to help people sort of figure out, where do I go? What do I do? What's the kind of work that you would urge students to focus on? Given all that you've learned, having been in the community in the midst of this crisis, and knowing that folks are about to enter a world where COVID is still going to be impacting, whether it's active or not, so much of what we're going to be doing. I'm wondering what advice you'd have for, especially our students.
Great question. I would say students should go and try to act as locally as possible. Try to find folks that aren't necessarily at the largest nonprofits or the largest providers, but find folks that have flyers up, that are, working with block associations or folks that are doing mutual aid and figuring out how you can increase their capacity. Because folks that have access to institutional knowledge that would come from the backing of the Mailman School and Columbia University, folks that have rich networks that they can call upon can provide a lot of different insight and resources and sweat equity that folks in community can really need. There are a plethora of different issues, everyone from figuring out what to do in the aftermath of COVID, of childcare, employment opportunities, figuring out how some folks are still food insecure. So it's issue agnostic, but it's really about showing up and being able to provide additional capacity for some of these folks that are doing the work day to day. Volunteerism, after they've gone to work, after they've tried to put their kids to bed, are still doing the work to make sure that their communities are whole and together.
Some of our first year students are looking for internships. We call them practicums. Technically, it's practica. And part of it is we want to get folk into community doing exactly the kind of work that you described. Forgive me for using this moment to make an ask. What have you got for us? Because I think people are very, very, inspired by the vision that you have of going to the community, speaking to people directly. That's so much more effective than, for example, looking at a body of data. Are there things that you can offer folk who want to get into communities and do this kind of activism, this kind of volunteer work?
Well, thank you for this opportunity to give a commercial. You can go to our website, www.citizensnyc.org. When you go there, you can sign up for our newsletter. In particular, right now, we're in the midst of getting all of these great ideas from all of these New Yorkers that are in their communities, doing everything from block cleanups to getting out there and providing folks access to vaccinations and health information, to helping folks get out into open spaces again. And all of our grantee partners are part of these wonderful initiatives that would really appreciate the opportunity to collaborate with folks that can add to their capacity. So if you contact us, then we can find ways to potentially get you involved with some of the folks that we have across the 5 boroughs in New York City.
That's absolutely terrific. You're drafted. You're now part of the Mailman family. Don't be surprised. That's really quite excellent. Dr. Frazier, I'm particularly interested in the work that you do in Brooklyn, because I have a number of students that I taught as part of the Bard Prison Initiative, whose homes are in Brooklyn, and many of them are doing work in Brownsville. And I'm very interested in thinking about things that you're doing concretely that might also engage members of our family here at Mailman who would like to sort of support your work and who are really interested, again, in doing the kind of community development that you're known for.
As I mentioned, going into beauty salons and barbershops, one of the things that you ask about advice for people is to listen, right? To listen to our communities. When I was in medical school, one of the things I was taught that if you listen carefully, your patients are going to diagnose themselves, right? So you really need to listen to what our community's needs are. And so having students come in and work with us and collaborate with us to develop curricula, to listen to what the needs are of the community, how they would like those things to be presented, how do we develop training for communities by community members and not by ourselves thinking what they may need. And so having students come in and work with us doing that work, also doing community-based participatory research. So with doing that research, there are students can help in terms of developing surveys and implementing those within the communities, assessing those, analyzing different things, and then using those to disseminate back the information to the communities. Because one of the things that happens oftentimes is researchers may go into a community, the community is seen as a pool for which to do research. You do that research, you're finished, you publish a paper, and that's it. As opposed to having that continuity with the community members saying, this is what we learned from you, and this is what we can do to change this, and how we can inform policy. We can bring our legislators together and give them recommendations based on the work that we have done within the community. And we always would like to have students teach our students in our Health Science Academy so that they can see people that look like them. They could see students that they can model, because sometimes they don't see a student in public health. They may not see a graduate student of color. So those are things that would be helpful for us. And you can do that by coming onto our website, seeing all the wonderful things that are being done there. We have also opportunities where we work with community-based organizations across New York City. And these community-based organizations are part of a Communities Together for Health Equity Consortium. We call it CTHE. And this is a consortium that was developed with district funds years ago. And we still work with those consortium members to look at social determinants of health. So we have opportunities for your students, and so they should just go on our website at www.arthurashe.institute.org, and they can find out more.
So I just want to say to everybody who's tuned in, you don't have to take notes. We are definitely going to make sure that this information is available so that in addition to the educational impact of a webinar like this, for some of you who are looking around for things to do this summer, I'm thinking of all the first-year practicum students, we got something for you. Thank you both. That was terrific. Dr. Maybank, I want to turn to you for a second because your career obviously fascinates me. You've been a commissioner of health for an entire county. You were a deputy commissioner of health here in New York City under Mary Bassett. And now you're at the AMA, located in Chicago, if I'm not mistaken. And I'm really interested in what it's like to go from so many different venues where issues of the health of the public, as well as medical practice, are sometimes all under one umbrella and sometimes seem to be very far apart. Is there something that you could describe that has been a kind of a synthesis of all the things that you learned having gone through many different venues where you've had to do the work, where you've had to focus on policy, but where you've also had to get things done? What in summary would you say has been the object lesson learned from all that travel?
Yes, it's a great question to frame it that way. And what I'm going to do is kind of root it in my public health background. You know, I think having the public health frame, so just simply the 10 essential public health services that y'all are going to be learning, that y'all should know, that should be committed to your memory in so many ways. And I had the fortunate opportunity to be part of the task force from 2 years ago that reimagined that and included and really embedded equity across all aspects of the 10 essential public health services. I say that because most of my career was in governmental public health. And so now I'm in this healthcare context, which we know there's an absolute kind of divide in many different ways of how public health systems show up and healthcare systems show up. However, the 10 essential public health services says to me that healthcare is actually a part of public health. Not everybody in healthcare will view it that way, but that's how I view it in order to kind of pull all of these pieces together for my context as I move forward in doing this work. And so as I, have transitioned through having this larger understanding of like what creates health, that's the other question fundamentally that is really important in this country, because most of the narrative around what creates health has really been in the context and the lens of where the power and the money has come from. And that's the healthcare lens, right? It's all within like hospital walls and doctor's offices. And most of you in public health absolutely understand that that's not the full narrative of health. But if you notice, like when we look at policy and the conversations that are happening, they're usually downstream. They're about insurance coverage. Not that it's important, or they're about what's happening in the health system, but it's not talking about health in the context of education, in housing and employment. And so I think, the thread for me is now where I'm situated is how does the work that I do and the folks who I'm engaging, how am I educating to really shift this, as somebody said, paradigm shift of what we understand, what creates health as a community across this United States, beyond just health and healthcare, and really get us more rooted in this broader narrative around health. And then tied to that broader narrative are the root causes, right? What are the root causes of what impacts injustice in this country? And so we're talking about racism and anti-racism. And I think it's really important as we talk about anti-racism, because I do hear, a lot of kind of mixture and confusion of talking about equity and anti-racism. And those two, they're two different things, And so I really push for us to talk about anti-racism, and racism being a system of power and privilege that benefits whites and disadvantages people with Black, Latinx, of color, of the spectrum of color, and Indigenous people, that also saps society, Kamara Jones will say. And so anti-racism work is recognizing how that system of power and oppression shows up in many different ways across our systems. And what are we going to do to dismantle that system that we know benefits some and doesn't benefit others? And the other part that I'm kind of stepping more into in this context of root causes of health inequities broadly is whose responsibility it is to do this work. Who should be held accountable? And I think oftentimes we know that Black and Brown people are put at the forefront of doing this work. I mean, it's human nature, right, for us to organize for ourselves and for what we love and for who we care about. So I think about Martin Luther King and the civil rights movement. It makes sense that we as Black people and young Black people came together and fought in March. And that's how a lot of justice movements are, right? They're led by those who are experiencing the most injustice. However, when we look at the definitions and the systems and who has created them and who's upholding these systems of power and oppression, we got to look to and hold accountability to those who are benefiting. And so this work is not just for us as Black and brown people. This isn't a pat on the back kind of work and somebody's doing us a favor. This is the work of white people too. And I really feel, and I say that more now, that when we look at how these systems are perpetuated and sustained, all of us have to really step into it. It's not just about allyship. Allyship to me is a passive way of thinking. It's about how are we knowing that this is all of our work, all of our responsibility, and we have the opportunity to be accomplices to dismantle racism that we know upholds white supremacy in this country.
Very dynamic, very powerful. Dr. Kwan, you're someone who is got a foot in the academy, but also doing a lot of work in the community. I'm wondering, as you think about the work of dismantling the system, how does that apply in the work that you're doing right now, especially the research that you've been engaged in?
Putting on my researcher hat, a lot of the work, I'm a mixed methods researcher and have been, have applied a mixture of qualitative and quantitative data in the way we approach our work. And that to me is, that to me is important because we know that there are biases and underrepresentation in data, in the quantitative data, and data is not collected without bias. There's bias within the data collection, who is being represented in the data, how it's being analyzed, and how it's being reported. And there's not always an opportunity for community perspectives and voices and experiences in the way the data is being presented, often because it's flawed from the beginning. And so we always marry the use of administrative data or public health data with narratives from the community. I don't think we can tell, we can't represent what's happening with the lived experiences with just numbers. Structural racism is a complex, dynamic factor. And so just reporting numbers is not going to get at some of that complexity. And so I really push back on the focus on big data, machine learning, and absence of context, and want to champion the use of thick data, the use of community narratives, personal, qualitative data, observational data from the lens of the community, to really share complex lives and lived experiences to inform the programs, interventions, and strategies, the way we try to sustain programs, and to really inform the research. And I just want to add also that it wasn't, I got my master's in epidemiology, and it wasn't until I did my doctoral work that included real qualitative research that I learned about the concept of researcher reflexivity in looking at data and really starting to examine your own biases and experiences in looking at data. And I really wish that lens was also applied more to quantitative research and to epidemiology, because I think there's real benefits in understanding where you're coming from as you look at data, and that quantitative data also comes with biases.
I'm recalling that, Dr. Kwan, I want to stay with you for a hot second. In our very first webinar, we had a conversation that included a variety of issues about data and about the problems we have often representing accurately the communities that we want to work with. And the example was given particularly of Asian Americans, where, for example, the tendency is to lump everybody together. Aggregate data on the Asian community often obscures what happens within the many communities that make up that collection of populations, so that the Hmong, for example, who are very different from Chinese Americans, the struggles that they have with health disparities are often left out literally because we don't have the tools to really get at the data that come from communities that are so small that in big data, we never think that they're worthwhile collecting. We always want to say that they are the other. And I'm thinking that narratives are one of the ways in which we get around that. When we hear someone's story, everything that's unique about them and their community now becomes a little bit more manifest. And I'm wondering whether or not, especially in the midst of COVID-19, there are stories that you've been hearing that are particularly useful for the conversation we're having about being anti-racist. I love the idea of paying attention to narratives. I wonder if there are some that you feel that you can share right now that would really help illuminate our conversation at this point.
I think that Dr. Nadia Islam, who is also in our section for in the Department of Population Health, also talked about some of the research we did disaggregating out health and hospital data to better understand what was happening in some of our Asian subgroups. We were hearing from our community partners that many of our Asian subgroups were being highly affected by COVID, and their experiences were not being captured in the data that was being presented. And we were hearing this over and over again in our Bangladeshi population and some of our Chinese immigrant populations. And so look, we went through and looked at the data from New York City Health and Hospital, and we were able to show that the Bangladeshi population, the Chinese population were actually experiencing high rates of infection as well as hospitalization. That wasn't part of the narrative that was being shared in the news media among politicians, and it really took us being able to disaggregate out the Asian subgroups to show that.
I really want to underscore that because I use the table from the CDC all the time. It looks at cases, hospitalizations, and mortality. And the Asian American community looks for all intents and purposes like the white community because of the way those data are aggregated. So I really want to underscore the importance of this point and why sometimes it's the narratives that give us a vision of the truth, more than the numbers ever could. Dr. Hass, I want to ask you a question about allyship and the fact that a lot of folk worry when they're in an institution like Mailman, how do I become effective in working in communities that are not my own? We have an international student body here. Folk want to become engaged, but they wonder, am I welcomed in communities that I'm not a part of? I want to do the work. I know the problems. I'm anxious to make a contribution. I'm wondering what you'd say to folk who wonder about whether or not, especially given the color scheme of our particular panel, there's a role for folk who aren't members of the groups that are represented here. Sorry to put that on you, but I think it's an important question I know people want to hear about.
No, it's a great question because when George Floyd was murdered and there was a racial reckoning, I alluded to the point that our work has always been about community, and our work has always been about trying to give folks the resources and tools to improve the conditions of their neighborhoods. The lens wasn't on the work to really look at people's differences as an asset and looking at people's differences as a way to really connect with them. And sometimes people make the mistake of trying to be race blind and difference blind. You actually can do more harm and prop up systems that give disparate outcomes to people of color, as opposed to getting the tools to dismantle them and to be able to make a difference. So I think the first thing is you don't have to be a racial justice organization to do anti-racist work. All of our work needs to be anti-racist because we have a linked fate. As one community of New York City goes, it's kind of like the canary in the mine shaft of telling where the other communities are going to go if you do not make an intentional intervention and try to get a grasp on the problem. So I think first and foremost, recognizing that we all are together is critically important. The second piece is once you recognize that we all have a stake in it, I think go in humbly. Don't go in with a savior complex that you have the answers, but recognize that you have a certain perspective that can be added, but go in with your ears and go in with humility that allows you to enter into communities. I also think that it's critically important for folks that are entering into a conversation about race to talk to folks who are like you about some of the issues of race, to kind of almost work out some of the kinks in your own community, because sometimes there is a policing of language, or sometimes folks are afraid to make mistakes. It's easier to make mistakes in safer spaces as you go out into others, so that you don't go in as offensive and don't go in making unintentional mistakes that are kind of propped up with the systems that we are. And then the last thing is, I say, it's really important for us to understand, to be tough on institutions and structures, but to be kind to people, to recognize that we're not always going to get it always right. And it's not a matter about being perfect, but if you can show up in a way that folks see that your great intentions are there, then you can be in partnership, because you have the humility, that you recognize that we have linked faith, and that you recognize you're not coming in as a savior.
That is really quite complete, very thorough. Does anyone else have anything to add rather than me call on folk? I think this is a really important topic for us to explore, given where we are and given the nature of the audience. Really, I think is tuning in to hear about exactly what you just proposed, Dr. Harris, ways of approaching this. Dr. Fraser, you have anything that you want to add from your experience?
Thank you so much, and thank you, Dr. Harris. I think that was complete. I think being authentic is so important, that you show up with your true self, but also really checking yourself, right? And really thinking about what are some of the anti-racist things that you need to do, and even checking yourself to see where you may be racist as well, and changing those things around, but really being authentic and really being sincere, because our communities can tell when you are just coming on to do a job, or whether you're just there because you need to check off something for school, or you need to do your practica, or you need to, whatever you need to do just to fulfill a requirement. So really understanding and listening to communities. And I think just when you come from a point of view of being authentic, you're coming from a point of view where you're thinking about the basic needs that people should have, and the basic things that the basic ways you should treat everyone, and not something that the power dynamics and so forth. But I think authenticity is really, really important.
Very well said. Very well said. Dr. Kwan, anything that you'd add? I'm thinking about the fact that periodically you're in a classroom, and this must be a question that you get asked as well.
I mean, Dr. Fraser's bringing up power dynamics, I think, is so important. And I think that there does need to be, whenever we send students to meet with our community partners and our community-based organizations, we do sit down with our students and our fellows to help them understand just the tip of some of this, that they're going in and representing themselves, the school, but they're there to learn, and that they're there to really. Yeah, I just want to echo what Dr. Fraser is saying. Like, it's so hard to kind of step back and try to instill that to our students, and to research teams that we also work with, who are interested in better representing some of the patient populations that exist within our health system, and taking the opportunity to stop and train them, to bring our community partners in, to lead those trainings, I think is so important. We really try to work in a bi-directional way, and really foster at those partnerships, because they're long-term partnerships for us. The work that we do, we're always trying to build and sustain the work that we're doing in and with communities. And so those are just really important steps that we need to take. Indeed.
And Dr. Maybank, I think about your career in public health when you were a commissioner, and when you had to send teams into neighborhoods. I know that when Dr. Bassett was the commissioner, you all really specialized on bringing the work of the Department of Health into the community. That meant that some of the DOH workers had to figure out how to leave their desks and actually be in places that they might have had all kinds of data about, but maybe they had never really functioned in. I'm wondering about the approach that you made in training folk to do that kind of work, because having set it up, I know that the next thing you had to do was actually staff it, provide it with resources. And I'm thinking about, what did you do when you sent a multi-ethnic, multiracial team into communities to do the work of the department?
Yes, I mean, so this was really rooted in a lot of our work that we called Race to Justice. And so it's related to, I think, overall looking at what an institution has to do to really embody anti-racism work. And knowing that it's not just an external opportunity. So it's not just about how we engage with communities. That's an important part, but what's going to influence how we engage communities? So for instance, how do we communicate? What are the equity and anti-racism principles that we're setting up for our systems as an institution? How are we doing budget and contracting? How are we doing procurement? How are we doing workforce equity, right? All of those components that we all have on our institutions impact how well we are able to engage with the neighborhoods of which our institutions are located. And I think an important part of this work that I have learned that I think is the unique part of what I bring and what Dr. Bassett really allowed me to do was the internal approach to organizational change in order to influence the work. A lot of folks want to step into anti-racism work and equity work without focusing on their own inside ways of being as individuals and as individuals and employees within an institution. And if you as an individual and as an employee that has no clear understanding of even how to define racism or anti-racism or equity, and then how it shows up in like your mental models on a daily basis, how it informs the decisions that you make, whether it's program, whether it's policy, whether it's data, we need to develop that critical consciousness again and that awareness of how to do that. And so our approach was, let's build our team's capacity in knowledge and skill set so that it can inform how we did set up our neighborhood teams, what was important in order to be there in our neighborhood spaces, and that we needed to be in the neighborhoods themselves, like physically located and have offices there, as you all know, they were district public health offices and neighborhood action centers, et cetera. And then it was much more, we had a better ability, I think, to then inform how we hired and who we hired. And that who we hired was going to be more connected to who was present in the community. But that's also a value shift, a value. And I think Rashawn kind of pulled this up earlier in terms of how do you focus on the assets and the strengths of communities and not the deficit-based model that oftentimes public health does all the time. We present those bad stats, right? But what's happening in a neighborhood that's actually helping it to thrive and survive through all these generations of oppression is really critical to building a space of racial, even beyond anti-racism, racial justice. And so what is that vision for us to do that? And what are the actions that do that? And that's fully built into valuing, our teams valuing and understanding that we are all equal, right? And people may say they think that, but the reality is that our data, whether it's workforce, whether it's health, shows us that people are not equal and we don't value people as equal. And so we have to really demonstrate that in how we engage and how we hire and who we bring on board to inform our processes. And so, you know, it's a different kind of work and a different type of consciousness, as I started before, as I said, rather in the beginning. And just the last point to that, you know, I just gave a keynote for this is like my alum week. I spoke with my med school through their white coat ceremony earlier this week, and now I get to do it with Columbia. And to the med students, I said, you know, history and context is important. And Dr. Bob, you know, you are like wonderful at sharing history. Like that, it was one thing that I learned many things from you, but history in the context of history and knowing that as you move forward in doing this work is critical. So the history of your institution of Columbia Mailman School of Public Health, learn about the history and its impacts in terms of what that means for the neighborhood and the people who are in that neighborhood, the good and the things that have been harmful, because those are going to rest in the memories of the folks within the neighborhoods that you're serving. So Columbia is one of them, but if you're going to another neighborhood within New York City, what is the history of the neighborhood and what is the history of the institutions? You can get some of that from the community members themselves, but you can also get that from, hopefully, some of the institutions will be honest and transparent and authentic about it. Some will not. But the important thing is to understand that there's a context, there's a history that reflects why people show up the way they do and how they can show up in the way that they do. And there's a cultural history And there's a policy and a kind of a structural history as well.
You know, I keep thinking about you and the fact that you're in the AMA. I think folk might have the notion that you were welcomed with open arms, and that as soon as you say, you know, after 100 years of deliberately excluding physicians of color, welcome, darling. We're so happy to see you. I have the sense that it was way more difficult. And I don't know that you actually share how hard it has been, but am I right? Because I think people have to be aware of the fact that when you challenge the system the way you have, there will be pushback. Am I right?
You are right. And so, you know, I would say me stepping into it in the year 2019, and this is the one reason why I was okay with stepping into it, was that it was, I'm so sorry, I have allergies, horrible. The reason I stepped into it is because there was policy that was passed by the House of Delegates. I knew there was something structurally that was going to hold some foundation to the work that I was doing. And it wasn't just kind of a mood of the moment. And so the Center for Health Equity is going to be there. So there was a lot of, well, visibly, there were lots of welcoming and open arms. AMA is democratic by nature. It is representation. What people don't realize about AMA is that there's representation from every single state that is part of the House of Delegates. So you can imagine it's going to show up by Congress in many ways, or any other kind of representative body of our country geographically. And there are certain fractions within this country that we know historically that have not supported equity work and justice work and anti-racism work. And so, yes, there has definitely been, since the release of the strategic plan and some other tools, some uprising and some clear resistance that is really, you know, folks like you say, oh, it's not shocking. And you know, if you would read some of these emails that have come like by direction and some of the comments that are made, it's shocking. Like, it's still shocking to hear the amount of hate, really, and just blatant like denial and dislike for people and intentions and just goodness. And so I've experienced some of that. Many folks know because it's been in the news. I've had death threats and I have to have security detail, and I'm in a conference now. That's why you see the blue tag in a hotel room right now, where I have to have security detail now when I travel because somebody actually came to my home door and wrote "die BITCH" on my door. You know, and I'm not the only one going through this. Michelle Morse, who is one of your deputy commissioners in New York City, you know, she's a good friend of mine, and I really relied upon her to learn a lot about how does one protect themselves in this work. And so just coming back to the theme of anti-racism, how an institution shows up to support its leaders, its workers, its students who are leading anti-racism work also is a part of the work. And to have an investment in that as well, especially during this time. This is not new, as we know historically. I always think about Ida B. Wells and how that had to be really hard. She had no security detail, going through different parts of the South, counting body parts for the anti-lynching campaign and all the work she did of journalism. So I reflect on that I'm not experiencing that. I have the ability to work in this institution that can pay for, you know, a security detail. But it's still hard, it's still stressful. And yes, I've had a lot of anxiety, you know, over the last couple of months, for sure, for myself and for my family. But working with lots of people. And I think the other important component of anti-racism work is organizing. We talk about Dr. Martin Luther King and organizing within our institutions and organizing at the community level, and the solidarity that can bring in the community, that can bring for each of us is absolutely critical to doing this work and advancing it.
You know, there are moments when I'm really moved by what it is I know you've gone through. For folk in the audience, I have a father and a grandfather who were both physicians. One trained in 1970, the other in 1934. Their experience as Black physicians in the South was heavily conditioned by what the AMA did and did not allow. Whether or not in a given county, for example, you had access to medical care if you were not white. These are all things that I think you've inherited as part of the legacy that you've had to push against in order to get this work done. And it leads me to the issue, Dr. Frazier, I'd love to have you think about it. how does one protect oneself? This is work that is not only stressful, the list of things that all of the panelists have laid out, things we have to confront, things we have to dismantle. I mean, that is probably not going to happen completely in the lifetime of any of us who are on this webinar. So the question of how you stay at it and how do you protect yourself? How do you keep going? How do you resist burnout? I think Dr. Maybank is absolutely amazing. But I think that all of us who do this work have these moments, these dark moments of the soul where you wonder, whoa, is this really going anywhere? Am I doing anything? I wonder what you'd say to that, because there are a lot of anti-racist workers who are on this webinar who really would, I think, benefit from the wisdom of folk who've been at it and manage to stay with it. You get up the next day and you continue to go to work.
Yeah, Alita, Dr. Maybank, I'm so sorry that you have to go through all of that, and it just recognizing the strength that you've always shown, and I just really admire everything that you do and that you still press on, right? And I think Dr. Maybank attested to some of that, alluded to some of that. It's thinking about those that have come before and on whose shoulders you stand. Thinking about the work that has been put in to get us to this point, although there's still so much more to be done. I think having folks that are like-minded and being in solidarity with others that help you to continue the fight, looking at the next generation, looking at those that are coming behind you, I think they often give us so much hope, right? That we want their tomorrows to be better than our todays, right? And so we do want to put that back in there. It is tiring, it is stressful. We've lived in communities that were totally ravaged by COVID. We're communities where we are always, we have normalized stress, right? Because it's become like that's part of who we are, and it shouldn't be. And we have normalized it. And then you had COVID come on top of that. You had George Floyd on top of that. And you have, and those are things that we are constantly going through. And I think as people of color, yes, we are resilient, and we have had to be resilient. Is that we didn't have a choice to do that in terms of surviving. But I think it often helps to turn to our faith, turn to the friendships that we have, turn to those that are in the fight and are in the trenches too, and holding up each other throughout that course. And then thinking about the history and thinking about where we have come, those people that have fought, as you know, as Dr. Maybank said, like I.B. Wells didn't have security detail, but still did that work. And there's still so much to be done if we want to help the ones coming after us.
Wow. Dr. Harris, I keep thinking about you because you are older than you look. I think it's okay to say. You have also had an interesting career because you've been in a number of settings where these are the issues that you've had to confront. And it seems to me with each new position, you have embraced an even bigger challenge than the one that you faced in the position that you left. What would you describe as your secret for hanging in there, holding on, and continuing to fight the fight?
No, I think Dr. Fraser said so much that was so relevant. I wanted to really lift up two things. First, find your people, community, your family, folks that believe in what you're doing, folks that have like-minded values, folks that might be going through the struggle, but particularly those that aren't in the institution that you're in, because sometimes if you're so focused in your own setting, that sometimes you need a different perspective, someone in the other space to give you the space to breathe, to be, to vent. And then the second thing I would say is really tenaciously go for joy, guard your joy, find moments of joy, whether it's through music, whether it's through exercise, whether it's through just doing the things that you really appreciate. Because life is really serious and the work that we're doing is so serious, but we really need to make sure that we don't take ourselves so seriously all the time that we can't find joy and that we can't release. And even releasing in the midst of darkness and even in the midst of struggle, that I think there are moments where you can find joy, and it's hopefully with your people, Hopefully it's, where you find your spiritual strength, and hopefully it's sometimes things that aren't necessarily so heavy, but give you a chance to really stay focused and centered. Particularly, you asked me about my career. I think it's really great to find mentors and sponsors. And, mentors aren't necessarily always about, will you be my mentor? Sometimes folks are sponsoring and provide you inspiration or opportunities if they're not necessarily speaking to you on a regular basis. It's finding folks that you want to necessarily potentially pattern where you want to go after, find ways to be in their audience, and hopefully create a mutual relationship where you can give things back to them. So you're not always just asking them for assistance and pouring into you, but find ways that you can get hopefully an intergenerational exchange or intercultural exchange that can be really, useful for both, that can make a real relationship that can endure.
Very good. Very good. Dr. Kwan, how about you? I'm sorry.
I was going to add something. I just wanted to add this one point, if that's possible.
Of course.
I'm sorry.
No.
I just wanted, because it's interesting how time evolves, but hearing like Marilyn and Rashawn talk, everything they said is exactly like the alignment that I have. And I think many others who are doing this work really coming to that space, and especially what Rashawn mentioned of joy. I had somebody tell me, and it's actually Gordon Chambers, who is a award-winning writer was Whitney Houston and Anita Baker. And I was getting music therapy because I needed something different to do, and something to kind of just take my mind off of all the stuff was happening. And he said to me in one session, he was like, Aletha, I get that you are fighting for freedom and justice, but your ancestors also wanted you to fight for joy. And so like that totally opened like the world for me last summer. And it just, I think what was good is that it set up a space that I've kind of already provided a cushion. So when these threats came along, I already, was kind of better in the practice of doing things for myself, the love for myself and the love with my family and my friends, as Rashawn and Marilyn have mentioned. But I just wanted to kind of put another kind of, point on what they all mentioned, because it's really, really important in doing this anti-racism work.
And Dr. Kwan, I was going to ask you if you had any particular reactions to this. In the last couple of years, your work has gotten way more intense, given the tenor of the country, from the notion that President Trump was describing this current crisis with COVID-19 as the Chinese virus. Seems to me that this has been a moment when you've had to deal with a lot in addition to your duties as an academician. And I'm wondering whether there are secrets that you've sort of figured out how to use so that you can get through this period, do the work, but also survive and find joy. Dr. Bhaymak, I love that piece.
I just want to also send Dr. Maybank a virtual hug, because what you're going through with the threats to yourself and your family is unspeakable. To answer Dr. Bob, your question, I've been focused on Asian American health for a long time, and often it's, the discussion is trying to prove that the community is not invisible and that there are real subgroup differences and challenges in accessing healthcare, and a lack of resources and programs and interventions and strategies for our populations. And that language access really is a big hurdle that is a structural issue that needs to be addressed, and that there are strong stereotypes about the communities that everyone is doing well because the data shows that in the aggregate the Asian community is doing well, and or that that the community is foreign born and are not Americans, right? So, and that really played into what Trump's message was about the Asian population. So this period where anti-Asian violence is being reported now in the media, and that there's attention to it, it has created a situation where we feel very much the need to kind of not let this moment pass, to be out to to talk about the data and the health disparities that Asian Americans face. And it has been stressful for us, for me and my colleagues, and similar to what Dr. Maybank and Fraser and Harris said, it's really being there for each other as colleagues and creating our network to support each other, to make sure that we're taking turns and sharing the load in doing the work that we're doing and talking about what's happening in the communities. And often, it's also a lot of pressure because we often get invited to do these talks and our community partners do not. And so being really meaningful and authentic and representing their experiences and what's happening and pushing to get more coverage within the communities is something that, we work really hard to do.
Very good. Dr. Fraser, I have a question that's related to COVID-19. I saw, I think it was in the New York Times today, an article that looked specifically at COVID and diabetes. It was really quite fascinating because it appears that of all the comorbid conditions that are particularly problematic with COVID-19 infection, diabetes leads the pack. And because that is a particular problem for Black and Latinx communities, one has this hope that now that we've seen how much COVID-19 has highlighted health disparities in our communities, but especially diabetes, wondering if there's going to be a change. The point that the article made is that diabetes kills hundreds of thousands of people, 100,000 people a year, but it doesn't receive the same level of attention or concern that cancer or heart disease or even HIV does. And so folks are thinking that maybe in a new world, at a new moment, now that it's become clear that this is something that deserves our attention, I keep thinking about your work, thinking about Brooklyn, and thinking about the struggles that many community groups have had to help folk find access to a good diet. Some of the food deserts in Brooklyn are really quite amazing in terms of their depth. And I keep thinking that's something that I know you all have been focused on. When you have some notions about COVID-19, work on chronic conditions that are part of the health disparities umbrella, and ways in which maybe COVID-19 is going to help you focus on that work and get the resources necessary to do it?
Oh, yes. And thank you so much, Dr. Bob, for talking about that. It's amazing that when COVID-19 happened, suddenly people recognized that there were health disparities. And we have been dealing with health disparities so much before that, right? And diabetes is one of those, like when you look at amputations in people of color and you look at the disabilities that happen as a result of diabetes. And it's something, and diabetes is one of those conditions that can be managed, right? And if diet is changed, and exercise and so forth. But while we may be telling people, and this goes to, in addition to diabetes, to the other diseases too, we may go out there into communities and we may educate people and talk to people about, changing diets and making sure you have fresh fruits and vegetables and make sure you have the places to walk. And I know, Dr. Bob, you know where I'm going with this, because we say all of these things, but in our communities, they don't have that, right? You have the food deserts that you mentioned. You have a lack of specialists. So endocrinologists may not be there. Nephrologists may not be there within our communities. They may not take the insurances that our people may have, the insurance that our people may have. So although it's brought to the forefront, we hope that we can change policies and we could change legislations that could make this something that could be addressed and that our communities could lead better lives, because COVID has shown us what's out there, but if something else comes, we're not in a place to even survive certain things, right? So we need to make sure that we have those infrastructure in place, whether it's within the communities, that we're utilizing those natural strengths within the communities, those people that are the champions and the leaders within the community, to bring those things to the forefront, to help our community members to make changes, but also change legislation so that we can have access to those things. And we know that if they are in place, the outcomes will be better. We know that, and it's sad that we know the solutions. We do know what those things what could happen if those things are in place, but making sure that we are doing them and making sure that we are saying, is this equitable? The choices that we're making here in policy, does this change the needle, the things that we want to happen? Are we doing things that could change and shift the paradigm, so to speak?
I'm wondering what Dr. Maybank about the AMA, because I mean, I think this is an issue that's sort of ready-made for our leading medical institution representing doctors. What COVID-19 driven policy changes can you see coming down the pike, especially for the AMA?
Yeah, try to be as optimistic as possible. I think, and I don't even have a full answer to the way that it was framed for Maryland, actually, because I'm thinking about this, and I think the opportunity is that, one, it definitely has been elevated, it's named, it's on people's consciousness in a way that it hasn't in terms of inequity, specifically as it relates to diabetes, but so many other kind of opportunities as it relates to this equation of inequities within this country. The challenge in the work is rooted in what we all know and have learned in public health of what supports creating health, and those are around the structures and the policies and the laws, and then the lenses that are used to create those laws. And then the people, let me go to the people who are responsible for putting those laws in place, right? And then you have the folks who have to organize, in communities. And so when I think about AMA, we have a pretty large voice and powerful voice in the halls of Congress per se, as well as on state levels as well. And I think our opportunity is going to be to continually be present, to advocate for changes within the healthcare space itself. But I think even more broad than that, because as I mentioned before, it's not the full narrative of health. And, if we as a healthcare, I'm going to say community and medicine community overall, does not have greater advocacy to the social and structural drivers of health, and this to say social drivers, I think the impacts that we have are going to be not as great as we want. And it's not just the medical community, it's right, all of our communities, because we all have that gap in understanding what creates health. And we don't really all come together in solidarity either. And I think about Heather McGhee's book, The Sum of Us, and this intention and idea around the solidarity dividend. And when Dr. Kwan was speaking, it came up in my mind as well. I don't think we operate well enough yet in solidarity, even across race and ethnicity. We tend to operate in our silos of race. And that's a tool, it's a strategic tool and a powerful tool used by white supremacy, or upheld by whiteness, that still exists to this day. And I think for us, when I think about organizing, whether it's the AMA or us as, health students or MPH students and public health leaders, it's how are we shifting a paradigm, and how we organize, who we organize with, and what are we organizing about as it relates to health, so that it's not your typical downstream opportunities, it's not with our typical partners, but we're pushing with solidarity. But a lot of this, it's up to the will of a small group of people in this country who still have power, predominantly white men, to make decisions however they want to make decisions. And we see it play out. And how we change that, I'm not fully clear.
But that's one of the reasons why we continue to ask the questions and probe to see in all of our conversations, we can come up with something that looks like an answer. Dr. Harris, I'm particularly mindful of the role that you played, because certainly one of the crises that I associate with COVID-19 was one having to do with housing. Of all the things in communities of color that weighed heavily in just about every element of the pandemic that you could imagine, everything from living in crowded conditions where social distancing was impossible, to the large number of people who lost their jobs and therefore were really quite precariously housed because they never knew whether they were going to get evicted or not. I know that you all do a lot of work on that. So I keep thinking about COVID-19 and the impact that it's had on thinking about what we do with community housing. Is that an appropriate focus for some of the things you have been trying to do?
The great thing about our work is we understand what the needs of our community are based off of the applications we get from community members. And Talking about systems change, I think who gets resources to be able to do their work lots of times aligns with power structures, and those who have get opportunities to get more. And what I think Citizens Committee has been able to do is that we've been able to democratize this type of philanthropy and act by giving micro grants. So being able to get a grant for $2,000 or $3,000, and sometimes folks that don't even have, the nonprofit status known as a 501c3 as registered with the IRS, being eligible to come together to identify a need and to be able to act on it and advocate for policy changes or changing conditions in your neighborhood is one of the most powerful things that we've been able to do. So as you ask about housing, one of the grants that we were able to make was to this one woman who is helping folks learn how to get access to resources that put them on a path to home ownership, and being able to lift up voices for folks that are being able to provide that kind of capacity building and community going forward has been very meaningful. Another thing, if you looked at our grants that were in 2018 versus what happened in 2020 and 2021, providing for some of the basic needs that folks had, provision of, food pantries and some of the mutual aid that happened in the moment allowed us to help folks that mobilized in the moment to be able to address some of those community needs. Another thing that happened that's kind of related to housing related issues is when schools were closed, people were in their houses with their children without a lot of educational supplements. And we were able to identify teacher training programs that were from the CUNY system and teacher trainers where they are in community, and some of the spaces where our grantee partners were to allow for some of the partnerships for folks to come together that hopefully in a socially distanced and safe way that they can meet in community versus meeting in some of the schoolhouses. But ultimately, it's about hopefully listening to folks in community as they solve their own problems or come up with solutions, and providing them some resources that they can experiment and be able to make a difference, whether it's advocating for housing, better education, or other needs that they have.
Very good. And Dr. Kwan, I'm thinking about what happens in the narrative about community life that one gets through a proposal for funding. And I'm wondering whether or not the narratives about COVID-19 have given you some sense about health disparities work and new opportunities to do research based on what we've uncovered as a result of the crisis that COVID-19 presented, and maybe taking some of your work in a new direction, or you're pretty well clear that COVID-19 was so bad, you got to keep on doing what you've been doing because nothing got better. If anything, things got worse. Just sort of interested in whether or not there are new directions for your own research agenda that have been that have really been sort of highlighted by what's been happening with COVID-19.
I think it's re-energized the focus on policy level work and working across institutions and really engaging with our public health system, working with our Department of Health, working with health systems and other institutions, as well as policymakers, to continually share what's happening in our communities, asking for better data, asking for data that's disaggregated so we can better allocate resources and develop programs and policies. We're doubling down on the policy level work. I think also Dr. Fraser mentioned this too, like food insecurity because of the COVID situation is something that is so intertwined with health and is something that COVID has really laid bare. And so we really need to, if we're talking about diabetes, we're talking about COVID, we really need to focus on making sure that families and communities have access to food and to address food insecurity.
Very good. I see that we're about 3 minutes away from 7 o'clock when this is going to end, and I see that our artist Abby has finally been able to sort of do a great deal. This is quite a wonderful array of topics that we've raised, images of the folk who raised them, and some of the key points that I think we have tried to emphasize throughout all of this. a radical orientation. I think fundamentally that's what we're about. And I think that radical orientation that is directed at root causes, I want to hope that in what has been for me a really fascinating conversation with our guests, we're focused on some of the things that remain for all of us to do. Dr. Joseph, this is the time when I always like to turn to you to sort of have the closing word, especially since so many of the things that we have heard about offer folks in the mailman community opportunity to get out of the classroom and maybe do some of the things that we study, that we read about, but which definitely require what I would want to say is the mailman touch. Final words to you, sir.
Yeah, thank you, Dr. Bob. And I just want to say just such a powerful panel session this evening. When I think about this theme, how to be an anti-racist public health practitioner, how do we become anti-racist? I think, Dr. Maybank, you said it beautifully in the beginning, in some of your opening remarks. This is not the work of only Black and brown people. An important first step is truly believing, as individuals that racism is not this person's problem or that person's problem, but it's all of our problem, and we all have a role to play in combating racism. Is it easy being anti-racist? No. We heard from our panelists, it doesn't take much to be authentic, right? It doesn't take much to have a sense of humility. It doesn't take much to be great listeners, or to not have that savior mentality. The bottom line is that we all have a role to play in fighting racism. It's not going to be easy. I think back to Frederick Douglass, when he said, if there is no struggle, there is no progress, right? So there will be some bumps in the road, but individually and collectively, we can navigate through these bumpy roads together in becoming anti-racist public health practitioners. I would like to extend great thanks to each of our panelists, Doctors Frazier, Harris, Kwan, and Maybank. Thank you so much. We appreciate you taking time out of your busy schedules to contribute so beautifully and so dynamically to this topic on how to be an anti-racist public health practitioner. So thank you again. I also thank Dr. Bob, you have such an exceptional way of moderating panels like these, Bob. These panels wouldn't be as exciting or as engaging if it weren't for you. So thank you, my brother. Appreciate you. Also, a great big shout out to Abby. Abby, thank you so very much. Your real-time capture of this evening's discussion through this wonderful drawing is nothing short of amazing. So just keep in mind, I will be in touch later for my caricature. So thank you so much, Abby. But last but not least, I just want to quickly give a shout out to some amazing colleagues I've been blessed to interact with during this past year in putting together these Face Forward anti-racism panels. This is our fourth. Big shout out to Lisa Herrera, exceptional project manager at the Mailman School. Big shout out to G. Capone, extraordinary interim director of diversity, culture, and inclusion at the Mailman School. And also a big shout out to Leah Hooper, the best senior director for teaching and learning in the country. There I go. This is awesome. The planning team. Thank you so much. Thank you so much.